Thank you. Thank you, Odisha State ESICON, and all my seniors, colleagues, younger ones, for remembering again and again. Thank you, Dr. Mishra. Thank you, Dr. Everyone. And I love to come to my second home. Thanks a lot. And thank you for giving this oration of Behrampur oration. I will be spending next 30 minutes on eTEP, on inguinal hernia repair. And it is beautifully said by Benjamin Franklin that being ignorant is not so much a shame as being unwilling to learn. And frankly, we have been following this for ages, that one has to unlearn, learn and relearn. And we strongly feel that if you are not updated, you are outdated. Today we have to think that we are the old crow or we are the modern crow. If you want to remain a modern, updated, learned crow, then carry on unlearning, learning and relearning. And same is true in inguinal hernia repair. I would remember when I was doing my thesis in RML hospital on shoulders repair under local anesthesia. That was the gold standard. Before that, Bassini was the gold standard. Then came the Lichtenstein, the gold standard. Then became the laparoscopic surgery, the gold standard. So what I mean to say, every time the gold standards are changing. And if we do not change with time, we will be preserved in museum. And today I am going to speak on eTEP, TEP, totally extraperitoneal, but E is enhanced or extended laparoscopic hernia repair. And I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. This was a publication by Jorge Dias in 2012. Why did I choose to mention that 2012, 1 decade has passed and enhanced viewed eTEP was started, and he had given this concept of doing the hernia repair with an enhanced view. What I mean to say, what is enhanced, what is extended, especially for my younger colleagues, is that if the artist is drawing a painting and he loves that whatsoever he is doing, but he just withdraws himself like this and then sees the whole perspective. Same way, when we were doing the TEP, when we were doing the TAPP for inguinal hernia, many times we would find a challenging situation, especially in obese or morbid obese patients when we were doing hernias, or if the span of the pubic bone and the umbilicus was less, then we were working very, very close to the area of interest. But when this concept of enhanced or extended view was given, then all of us started thinking and finding it that ultimately, if the space is big, if the dissection is excellent, we will be able to prevent the ultimate recurrences. The thought process is that one should definitely upgrade oneself and try to reduce the recurrence to duck as far as possible if we are doing the inguinal hernia or if we are doing the ventral hernia repair. And as all of us know, that one has to unlearn, learn and relearn. And this is the a slide from my book which I had written in 2001 on laparoscopic hernia repair, and this shows that this is a right inguinal pre-peritoneal. Whether we are doing TAPP or TEP or eTEP, principles or the anatomy remains the same. Means one should know that this is the iliopubic tract, one should not tack it below, one should not cause any vascular or neural injury. So one should know the anatomy very well. And this concept of critical view of myopectineal orifice, I think this has got to go into the minds of all my young surgeons, so that ultimately we do not have to face the recurrence later on. And in this situation, if one is going in as in laparoscopic surgery, the critical view of safety became so paramount that there should be two structures, cystic artery and cystic duct. Similarly, here also the critical view of safety or critical view of myopectineal orifice one should know thoroughly, and for this I would urge my younger colleagues to go into the annals of surgery and look for this critical view of safety. And in this of the myopectineal orifice, in this it has been divided into 9 steps, and if you follow it tooth and nail, then the chances of recurrence are reduced to nearly 0. In this, for example, if the critical view of safety, one has to dissect the pubic ramus, one has to go in and do the dissection posterior to the pubic ramus into the cave of Retzius, so that when the bladder is getting distended, the inferior margin of the mesh should not go rolled up. That means 2 centimeter of the dissection has to be there between the pubic ramus and the bladder. 1. Then as we start moving laterally, one should always make sure, this is the inferior epigastric vessels, so one should always make sure that we empty out the Hazelback triangle. Means all the fat or the direct sac has to be taken down. Then only the chances of recurrence will be reduced. And as we move or march laterally, lateral to the inferior epigastrics, and then we start going close to the corona mortis. I will be dwelling for a few seconds on corona mortis also, and then one should always be able to do the dissection close to the femoral hernia defect, so that we do not leave the missed hernias. And again, the vas deferens has to turn medially, testicular vessels has to turn laterally, and the peritoneum has to form the horizontal limb of the equilateral triangle. And then laterally, as we go laterally, then the dissection has to be such that we are able to create such a space that we are able to place in a size of mesh of 15 by 12 at least. That is very, very important. So as we know that we always divide the problem or challenge into small steps. So 10 steps of eTEP, the position of the patient, position of the surgeon, and an assist. More important is when we are doing the eTEP, we start from the left side of the patient and we make one port. I will show you in details. One port on the left side of the midline, and through that, through the optical entry, we go and make a retro-rectus canal. And then we make 2 ports in the midline, as we had been doing in TEP also. But again, there are surgeons who make the contralateral as well as the ipsilateral ports. We have nothing against it. Our thinking is that if we are able to do the right side hernia with one primary port of 12 mm and 2 5 mm port in the subumbilical region, enough. If we are doing left side, we can change the side to the right side of the patient and do the dissection. And if it is a bilateral hernia, then also we are able to do it with 3 ports. So ultimately, but nothing against those surgeons who are making the 4th port also to do the bilateral dissection. And again, optical entry. I will show you the small video clipping in which we follow the OptiView port and go layer by layer. Eyes don't lie. And then again, we should always make sure that we are following the white, means pubic ramus, pubic bone. Laterally, we go into the peritoneal area, work in the pre-peritoneal area, and then we create such a space that we are able to place in a mesh nicely. Yes, the chances of seroma formation have to be reduced. So direct defect, one has to maybe fix it to the Cooper's or to the rectus abdominis. Indirect also, if possible, reduce the complete sac so that the chances of seroma formation is reduced to 0. And then mesh rolling. If we are doing eTEP or TEP, we roll it onto the floor. But there are surgeons who would do it onto the roof, nothing against it. And again, when we have placed in a mesh, it is a good idea to check, recheck, cross check, counter check, check and check that whether our mesh has been placed nicely or not. Now in this situation, one can see that we are standing on the left side and the hernia side is on the right side. Again, as we have been comfortable with TEP, with these two secondary ports, the upper port, that means the scope, one can see that it is quite far off. So once it is far off, then definitely it helps in dissection. And then once we go in, again one can see that we are going with skin, scampers, scarpa, and rotatory movements of the 360-degree rotatory movements are there, going layer by layer down, and then we will find the anterior rectus sheath. As soon as we find the anterior rectus sheath, we are carrying on doing with the 360 rotatory movement, and then now you see the anterior rectus sheath is going and the rectus muscle is coming. So once we go into the rectus muscle, and then we would change the direction of our push into the space, rectus space. That means we would place our port in such a manner that we do not perforate the posterior rectus sheath, and we carry on insufflating the space. At this stage, it is very, very important that if we insufflate the space, then it forms by itself, and then we are able to go and make a drone kind of movement. That means we are going rectus, pre-posterior fascia, posterior rectus sheath, and then we are able to create the space. And this is the space one has to work in. And as soon as the space is created, then we make the two secondary ports with the help of needle and syringe. We call this as GPS, so that we know the direction of our ports. And these ports are made, again, piece of caution, that please do not try to injure the inferior epigastric vessels. Many times I would say that in such a limited space, if you are not knowing that inferior epigastric vessels are giving branches to the rectus muscle also, then the chances of bleed are higher. And if the bleeding is there, the space is limited, it will become dark and it will cause challenge. And we had been using way back in 94, 95 balloon dissection, but for last 3 decades we are not using any balloons, and then we are able to make the ports. In this situation, one can see that this is the pubic bone, this is the anterior superior leg spine, mid-inguinal point, we draw a vertical line, and then first port will be medial to the semilunar line. That is very, very important, medial to the semilunar line, and then we go down and create a space. Again, in this situation, for example, when we started our career of TEP, then we were making this space by placing a port on the infraumbilical area, first primary port at the infraumbilical area. But again, if the span is less than 15 centimeter, we definitely had challenges. If it was a large direct defect, it was a challenging situation. So it is better to carry on unlearning, relearning, and then updating ourselves so that we are able to do a better dissection. And again, as we start moving from medial to lateral line, especially my younger colleagues should remember that fascia transversalis is a bilaminar layer. This is a fascia transversalis, and this is the space in which loose areolar tissue is there. So if we are working in that loose areolar tissue, we will not cause any bleeding. But if we are working anterior to the fascia transversalis, the blood vessels, the inferior epigastric vessels, the branches of the inferior epigastric vessels can be injured and they can cause bleeding, and that can be challenging later on. So it is a good thought that know thy anatomy well. And then again, what are the causes of recurrence? I have a presentation on recurrences, cause and management later on in the guest lectures, but I would say that please take care of the lipoma of the cord. Anytime lipoma is there, just take it down so that ultimately the chances of recurrence are reduced. Similarly, one should not rub onto the obturator now. One should not cause neuropraxia, and this is the place one can appreciate. This is the place of corona mortis. The pulsation can be seen. So please do not rub onto the Cooper's ligament also, because if we rub onto the Cooper's ligament, this corona mortis, crown of death, can bleed like hell, and the surgeon starts thinking, why was he born? What I mean to say is so much of bleeding can occur, so one has to be very, very cautious about that. Again, follow the white. That means remain extraperitoneal rather than extra fascia transversalis. And then what should be our dissection? Ultimately, we have to make sure that we are going up to the psoas posteriorly. We are going and laterally also to the 2 centimeters anterior superior to the anterior superior iliac spine, so that when we are placing in a mesh of 15 by 12 at least, there are no curls and curves. Many times I have seen that if space is limited, if the dissection has not been done adequately, there will be some upheavals or curls and curves on the mesh, and that can lead on to challenges. So one has to be very, very careful about that. Again, the vas deferens medially, testicular vessels laterally, external iliac vein, and this is the peritoneum. The peritoneum has to be taken down, and it should become a horizontal limb of the triangle of doom. Then only we should call this as a complete dissection. If you have not done a complete dissection, then the chances of recurrence are definitely increased. And then, as I mentioned, that one has to reduce the chances of seroma formation, and one can tack this pseudo sac. This is the pseudo sac one can see. So if one tacks the pseudo sac onto the Cooper's ligament, the seroma formation will be less. The chances of recurrence will also be less. And if it is an indirect defect, then also we should try to reduce or remove the fundus of the sac, and then ultimately make sure that if it is a large defect, then cover with the mesh, larger size mesh, fix it onto the lateral aspect as well as onto the Cooper's as well as onto the rectus abdominis. But if it is a small direct, less than 3 centimeters, less than 3 centimeters indirect defect, then this mesh is enough. One can see the mesh step number 7 is mesh rolling. So we fold it in such a manner that half of the mesh is folded in and half of the mesh is not folded, and then we place it in such a manner that this is the rounded portion of the inferior margin of the mesh. It is onto the bladder. I have seen on cystoscopy the corner of the mesh going into the bladder. So one should always round it off rather than having a hematuria later on. And then when we are laying down the mesh also, one should be very, very comfortable that we should not cause any curls and curves. There should not be any interference, and it should be fixed at 2 points at the Cooper's ligament. Once the 2-point fixation at the Cooper's ligament has been done, then this middle portion of the suture is taken away, and then unfurling is done onto the floor rather than onto the roof. And again, when we are doing the bilateral inguinal hernia repair, please make sure that the midline has the overlap of, because it is the medial most recurrence which is commonest. Medial most recurrence is the commonest, whether we do open, whether we do laparoscopy, whether TAPP or TEP or eTEP. So please give extra marks to medial dissection, because ultimately we should not be responsible for causing any infection later on or any recurrence later on. So in conclusion, I must say, and especially for my younger colleagues, that we have to decide, you have to decide, you want to remain an old crow or a modern crow. Means old crow used to put this pebbles into this pot, whereas now the modern crow you had seen in the beginning also, and it is using the straw to suck the water out. Thank you very much. Keep upgrading your skills. Thanks a lot for this opportunity.